thank you very much for coming today to here at the Village Hotel here in Ashton. I'm Dr. Aaron Mann. I'm the chair of the Greater Manchester Association of Greater Manchester LMCs and also the chair of West Pennine LMC. And today it gives me great pleasure to invite Krishna Kasaraneni to come and talk to us about some of the changes that are going on or that are going to happen with GP Contract. We've got an incredibly difficult time at the moment, and I'm just looking at the news this week. We've lost another 200 GPs from general practice in the last 3 months. That's on a backdrop of the idea that we should be having 5,000 more GPs. I know that we all feel incredibly stressed and we're wondering about where the future lies. Clearly the GP contract will have a big impact on how we feel in the next year, so I'm really looking forward to some of the wins, some of the losses, and some of the what can we do about it. Krishna is very keen for us to be quite an open discussion rather than a lecture, so I'm quite happy for him or for you to ask questions and have more of a discussion rather than a lecture. But over to you, Krishna. Thank you very much.
Thank you very much, Aaron. Thank you. But firstly, apologies, I'm recovering from man flu, so if I'm losing my voice or if I feel a little run down, please do bear with me. I'm nearly there, but I'm afterwards, but it'll take me a little while to recover fully. My name is Krishna. I'm a GP from the right side of the Pennine, so I work in Sheffield and Rotherham, as well as the medical director for homicide LMCs and part of the GPC executive team. And like I said, I'm not here to talk at you. I'll talk to you about the kind of things that we want to cover in the next hour and a half, but let this be a fully interactive thing. Put your hand up anywhere in the presentation and we can have a conversation as we go along. And there's about 45 slides, but as I said, the notion of speaking for 1 hour and taking questions from you for half an hour isn't going to be out there. But somebody will fall asleep. So before we kick off, if I could just ask a really quick question. One of the things we're trying to do with GPC is when we go around the country speaking to GPs, GP practices, practice managers, we want to get a feel of who it is that we're addressing. So we don't come to you with what we want to tell you. We actually address the issues that you have and what are important to you. So on that note, can I just have a quick show of hands? And you can put your hand up more than once. How many are practice managers in the room? Okay. How many are GP principals, GP contractors? How many salaried GPs? How many local GPs? How many tenancy officers? How many CCG officers? Any NHS England spice? No. Press? No. Okay, that's good. Okay. No one's speaking to. Right, in terms of what we're going to try and cover. Oh, sorry, can I also introduce you? Kira Green. Some of you may have heard Kira's name or seen Kira from Kira. So we work as a team within the BMA, so sort of the looks and the brains of how we function in that order. So Kira deals with the premises as well as the main contract negotiations with the BMA. So we are going to take notes and feedback from you as we go along, because we may not have all the answers for you. So if there are issues that you want us to take away and bring them back to you, we're more than happy to do that as well. So the kind of things that we want to talk about in the next hour and a half is to give you an update about the contract. We've not concluded the contract negotiations just yet, but I'll let you know where we are and the kind of stuff that we are talking about. And soon after Richard became the chair of GPC England and UK, Richard asked us to develop a vision for how we think general practice can be saved from the position that we're in. So we'll talk about saving the general practice document and the kind of stuff that we're lobbying members of Parliament, government, NHS England, as well as other stakeholders to try and really improve the situation for dental practice. There's some recent developments which will cover issues like GP at hand in London, as well as the recent GMC issues with a particular doctor in Leicester and all those things. We'll briefly touch on those, but any of those, feel free to just pause and we can have a wider conversation about the issues. And there is a session GPs update, considering there are no session GPs in the room. I'll just let you know about the kind of stuff that session GPs, if you are employing session GPs, then the resources that are available to you, and updates to GP4U and working at scale initiatives, which I'm sure most of you will be familiar with and want to talk about. Does that sound kind of stuff that you want to talk about? Have I got it completely wrong? Perfect, so no one's throwing anything yet, that's great. So about the contract update itself. So in terms of where we are with the contract, first and foremost it's important to say that whilst there are many issues that can only be addressed by making sure that it's a contractual requirement and there's appropriate funding for it, there are also significant issues that are out with the contract that we need to be dealing with. Because simply negotiating the GMS contract and getting uplifts to it isn't going to be the full solution. I mean, on the indemnity, for example, when the 2003-4 GMS contract came into place, there was an element of funding in the global sum that was supposed to be for indemnity. we will all agree that that level of funding hasn't received the uptake and the uplifts over the last 14 years or so in proportion to the amount of indemnity fees has gone up. So we need a separate solution to indemnity, which is not necessarily within the contract itself, but we need to have a wider conversation about that. Things like workforce. Once there is an acknowledgement that the global sum is supposed to be for everything you need to provide for your patients, we have a significant workforce situation whereby numbers are dropping every single quarter, with the backdrop of the government saying that it will deliver 5,000 extra GPs by 2020. And like Alex mentioned, these are significant problems that we need to be looking outside of the contract, as well as things that we can do within the contract to try and address the situation. And contract negotiations, we haven't finished them yet, but we are getting pretty close, and hopefully as soon as it's formalised, we will let everybody know. What we are looking for is pay uplift and expenses by the DDRB this year, as opposed to what traditionally has been to the main GMS contract negotiations. I'll come on to the reason why we're doing it that way around this year later on in the presentation. But we're also looking for certain things like, say, commitment to uplift VAPs and ACMO service in line with the increased costs of delivering these. Most of these payments have been in the SFAs, the Statement of Financial Entitlements, for years at the same level and haven't really been uplifted. So whilst the costs of delivering those services for GP practices are increasing, the revenue we get from that hasn't been. So in a way, we've been making loss on most of these things. We do them because it's the right thing to do for our patients, and we feel that our professional as well as moral obligation for us to deliver them. But unless it's funded appropriately, we can't be expected to sustain that level of service delivery over a long period of time. So those are the kind of things that we're dealing with the contract itself. So in terms of where we are with the contract, we know what the CCG allocated funding for primary care is for 18-19. So that's about 188 million. With that money, NHS England can offer us a 1% pay uplift and an expenses uplift. 1% uplift actually means it's a pay cut, because inflation over the last year has been about 4%. If you look at the RPI number itself. They can obviously accommodate the population growth uplift, which they have to. If you have more patients, you need to get more funding to deliver that care. And the indemnity increase cover that was committed in the last year's negotiations, where they funded £30 million to accommodate for the increase in indemnity, and further £30 million on top of that this year, expecting a roughly 6 to 7% of increase in indemnity. Those are the kind of things that NHS England have already committed to looking at before. But what we cannot accept is another 1% uplift, which is a pay cut. So this year we decided to approach the DRB, and until recently we couldn't tell you what it is that we asked for. It's now in the public domain in the BMA sentence. Is we asked for an RPI which is 4% plus 2% uplift for pay and expenses for GPs. It's actually RPI plus 2% or RPI plus 800 pounds, whichever is more, but GPs, most intents and purposes, it will be RPI plus 2%. So that's what we've asked for. We've asked for that to make sure that it reflects the fact that GPs had a pay cut for most of the years, so pay needs to increase. It reflects the fact that our staff-related expenses and other expenses have gone up over the last few years, so that need to be factored in. And we've asked for that because there are new things that are happening around us which we are just simply expected to absorb with no extra money. And on the guidance of safe working issues, not very relevant to the Northwest as such, with the new junior GP trainee contract where there are no lead-employer arrangements, you have to now engage new staff to monitor the contract, which fortunately for you is too big an issue because it's supposed to be the lead employer's responsibility. That needs to be factored in. The issues with cyber security when computers crash. I mean, how many of you were affected in the region? Roughly, yeah. We didn't, but patients still didn't turn up because they assumed that we were already affected, so that was breath of fresh air for me. So, but I'm joking aside, for most people, for most practices who were affected by the cyber attacks, you have to absorb a hell of a lot of cost with reference to trying to address patient demand, writing notes on paper, then to go back and put them on the computers afterwards, issuing prescriptions. All of that, you have to do it at your own cost whilst dealing with the normal work. GDPR, the next big thing that's happening to the country, no, that's Brexit, but GDPR, the second next big thing that's happening to the country, which is not just about NHS, not just about general practice, but when that comes into place, the way data is processed everywhere is going to change. No one really knows entirely the impact it's going to have on the nation as a whole, let alone the impact it's going to have on GP practices who act as data controllers for patient records. But those are the kind of things that need to be factored in, and some of them we don't know how much it's going to cost, apart from that it will cost. It will cost a lot more than what we pay for now. So in our submission to DRB, we made it very clear that these are the kind of things that they need to consider and give us a pay rise that's appropriate, that actually incentivizes people to get into general practice and stay in general practice model. The other stuff that is very different this year compared to the last few years, if you, I don't expect many of you to have read the whole thing, but how many of you read the Department of Health submission to DRB? Please don't be carried away. Yeah, it's a very dull document. It will confuse you. Most of these documents will. But there's a huge change in tone from what the department has said over the last few years to what they've said this year. Up to last year, the rhetoric has been, we're doing this fantastic bits of work with new initiatives about recruitment, and we're going to retain this many GPs, and by next year we'll have that many new GPs joining and everything else. For the first time, certainly in my living memory on GPC, there's an acknowledgement from the department to say that it's not working, to say that GP recruitment is suffering, and we're not retaining GPs. Every quarter when NHS Digital publishes GP data, GP workforce data, numbers are going down. So in the Department of Health and Social Services this time around, there's a clear acknowledgement that something different needs to be done. And there's also been a statement from the Secretary of State that they're going to move away from the 1% pay cap that has been in existence for the last few years. And we don't know clearly what he means with reference to that. Does that apply to everybody, or does that mean he makes savings from one part of the health service and then put it in another part of the health service? But the rhetoric is different. It's the first step. I'm not going to stand here and say, yes, we're all going to get a 10% pay rise in the next 4 months. That's not realistic. But there definitely has been a change in mood from what everybody else is saying about us compared to what we've been saying over the last few years. So that's the reason why we decided to look at some tweaks to the GMS contract to try and get the uplifts that we need, but also make a significant push to recommending to the DRB that we need a real pay increase to help general practice get out of the crisis that we're currently in. What do we have so far on this one? As I said briefly before, the indemnity has been a huge issue. We all know what it used to be when we said there were junior doctors in hospitals, and I still remember I paid £10 for my first year as a house officer, and when I moved into general practice, it just there's kept getting a knob added to it as a trainee and then as a fully qualified GP. Whilst there's an acknowledgement from the government over the last 2 years to address that by giving some funds back into general practice to accommodate for the increase, what we know is that that simply isn't going to be enough, and there's a wider conversation about a fully backstayed indemnity scheme, which I'll come on to in a second. But this 30 million that's coming in, it is supposed to be for all GPs in a practice-based setting. So if you're a GP partner or a salaried GP, you're supposed to be getting reimbursed a certain element to reflect the increase in indemnity. It's easier if you, so like my practice where we have a practice policy, which covers everybody, you just get it as a practice payment. I mean, it hasn't covered the increase for us, but it's at least got the headache of how much do we give salary GP and how much stays in the practice spot and so on and so forth. The local GPs are very clear. They need to reflect the increase in indemnity that they're having to bear with in the cost of their charge practices. There isn't a number that you have to give local GPs back. And there's some resources available on the BMA website, and there'll be a template letter for salary GPs that they can use to try and get for the increase in their indemnity if you're in a setting where there isn't a practice policy. That's supposed to be for all GPs working in co-general practice setting. And as we said, we started discussions on the state back indemnity scheme for April 19. The idea for that one is that, and different people ask for who's going to be covered and who's not going to be covered and so on and so forth. That has to cover all staff in a GP practice. Well,
on your previous slide, you said indemnity should pass on to all GPs. Where you've got a practice where the salary GP has a separate policy and the principals decide not to pass that on, is there any repercussion, or is that just a kind of desire?
Well, I suppose an element of that will depend on the contractual arrangements between the practice and the salary GP themselves. But the principle of negotiation of this is for all practice-based GPs, because everybody's indemnity is going up. In fact, it should be for all GPs, but it's very difficult to factor that in to a local GP who does one session for you, dealing 17p or 44p extra. It's very difficult to calculate that number. The overarching principle is that should be for everybody. But if there's a separate arrangement you have that works for the practice and for that salary GP, it's not GPC's job to tell everyone how to do it, but the resources are there to deliver that principle that was agreed on and negotiated. So going back to the state back indemnity scheme from April 19, our position has been that it needs to cover every single clinical member of staff that's in the GP practice, the vicarious liability aspects of it. Because the conversation has been now that you need to expand the primary care team, it's not GPs who's going to be delivering everything, you need advanced nurse practitioners, you need physiotherapists, pharmacists, physician associates, all of these people in your team. And it then doesn't make sense to say, but only the GPs are going to be covered for the indemnity. What if you've got 2 GPs and 8 advanced nurse practitioners, like the practice in general does? Then how is the state back indemnity scheme going to help you? So it needs to reflect the setup that hospitals have. Bear in mind, hospital colleagues had exactly the same situation not that long ago, and they found a solution whereby it is going to be that state back indemnity scheme. We will still have our own personal indemnity we'd have to pay for, but that won't be as much as what we currently pay. So those are the kind of things where if you're in front of the coroner's court or GPC proceedings, that kind of thing will be covered. But the clinical indemnity needs to be provided fully for the practices, irrespective of which staff you engage, and it needs to cover everything. That's the position we take. The plan for that is it should come into place from April 19 onwards, so the conversations are happening at the moment, and as soon as we've got some concrete agreements, we'll obviously share that with everybody.
Will that, at the last conference I spoke to Richard about the issue of retiring GPs, and setting up a chamber with the GP federations. Would that indemnity cost be passed on to GP feds to fund the indemnity of GP chambers as well, providing NHS services?
If it's, in a way, if it's a GP chambers, but the principle is that the GPs within the chambers go to practice A, deliver the services for the practice A, for the work that they do in practice A, it'll be covered.
By the practice?
By the state back indemnity scheme. So it should cover that. It may not cover the chambers, but the work the chambers does for the practice, we want that to be covered. I'm saying it should be covered. It's not agreed, but what we're looking for is anything that's provided by that practice, the clinical practice, well, I shouldn't really say anything either. The services that the practice is commissioned to provide, those are the ones that are going to be covered. Okay.
Just ask about the state action. Is it looking like it's going to cover anything that occurred before the state back scheme? So the complaint comes in one, but something that happened 2 years ago, will they be covering that?
I suppose you're talking about whether it's the occurrence-based or... Well, essentially, those conversations are still happening. The way current practice is right now, we've made very clear when you're looking at an indemnity scheme, it's got to be about something that gives you cover forever. So most indemnity organisations will say that if you've been a member with us in 2014 and an incident happened in 2014 and that was raised in 2018, yes, it is still us who cover you for the 2014 event. So if some GPs do have variations of that, whereby it's, if I'm a member with you, it doesn't matter when that event's happened, if it's raised, we'll cover you. Those are the kind of fine detail that needs to be covered in the conversation. But what will be as, it has to meet the requirements that in fact GMC and NHS England have both stipulated with reference to the maximum amount of cover, the run-off period, and essentially the GPs who are retiring, that you're not going to be faced with an indemnity situation 10 years after your retirement because someone has decided to raise it. The other issue, moving on from the indemnities, is the issue with premises. Again, what we're doing with premises cost corrections, I realise before I go into any more detail that this has been in progress for a few years yet. We're hoping to announce something relatively soon. And I'm sure my colleagues have said that in the last 3 years as well. But when I say soon. But with premises cost corrections, we've acknowledged that premises is a huge challenge, particularly with the impact it has on the workforce. If you're tied into leases of 30, 40 years and you can't move on, you can't get anybody else to buy into it, and nothing that has been invested into premises, if you even want to, there's a huge barrier in front of you. You can't just improve your premises yourself, because that will have revenue costs on the board, so they may necessarily find a way to object it. There are many other things which makes investment into premises a very convoluted and a difficult issue to deal with. But what we're trying to do is to try and find a position whereby we are in negotiations with NHS England to find a new solution to premises whereby it can incentivize GPs to really invest into premises. It can act as an incentive for GPs who want to buy into premises, who want to buy into partnerships. But clearly, when we're in negotiations, not everybody sees the solutions as the same. So what we're hoping to do is, by the time we conclude the PCDs, is to come up with a new set of corrections which will enable a significant amount of the ETF funds to be spent on improving premises. We may not find a solution to everything, but what we don't want to do is to commit to something which actually increases the risk on contractors, increases the risk on people who sign up to lease arrangements with even bigger liabilities, an extra £1 billion worth of money. So we will have to get to a solution which involves some positive aspects which will help us spend the money coming from each year, but with a commitment about having a much wider conversation about premises situation. No other doctor in the country has to buy into, let's say, into their building. None of the hospital doctors have to go and buy a bit of the hospital to work in. Fine, I mean, I'm personally one of those GPs who will see this. Investing in my premises, for me, is a windfall. When I retire, which will probably happen at some time, is that I will have, my investment will give me a return which reflects the risk I've taken by putting my money where my mouth is and putting it into the premises, looking after my patients better. Not everybody else sees it that way, and some of them want leasehold premises. And the reality is that there isn't necessarily one solution that says, this is the one thing that will change the situation in premises. Or if we do it this way, suddenly everybody will become a GP partner and decide to build new premises and improve them. So what we asked for, on the other side are definitely interested in, is to have a wider conversation about the whole issue about premises. In the form of a commission whereby we look at issues of last person standing. And how many of you know of GPs who can't retire or will retire but are still on some form of practice leads with stakes in premises and they can't get out? The only way they can get out is a thing, I checked this, is when they die. So that's when the responsibility brings them. What kind of a sad situation is that somebody who's been a GP for that many years, invested in the premises, given it their all, and they can't actually retire with any kind of dignity because you tied into something that you don't want to be a part of. So we need to cover all of those things in the Premises Commission to try and say, are we serious about a partnership model in general practice? If we are, we need to get the premises bit right to make it an incentive for partnership and not a disincentive, which is what it is turning out to be at this point. That's what we've got to now on the premises.
The third parties, hosting third parties, especially with new rules of care, etc. And that, in 2014, the light was shone on that in the stage review. Is that realistically that's been taken out?
Well, these are the kind of things we're trying to put our case forward to them to say, look, if we are expecting GPs to work in new ways and in an integrated fashion, and not just a GP practice but community services based on the same organisation, the same building, you're going to have to look at that, because otherwise, how can you have a vision which doesn't fit the reality and the restrictions of a set of directions which stop you from letting you room onto the physiotherapist who will see the patients, or for social prescribing to happen in your premises. So they get that. It's how serious they are about making it a realistic incentive for GPs to do that. And it's no secret that in NHS API gets profit. So if you're making a profit out of renting your room out of NHS money, you can't make a profit. But how about looking at it as actually improved patient care? Profit's a byproduct.
Not just the rent in the room, potentially. You can invite the third sector to do something, that's a mental health, in a clinical room which is vacant 2 or 3 days a week. At the moment, my understanding is that you can be penalised by NHS and claw back that 5-10% of your reimbursement cost. And that's the reason. It's not a case of making a profit, it's just a case of actually, is it worth inviting the third party to do that?
Absolutely. Those are the kind of disincentives we need to remove. Because the current set of PCDs, the 2013 ones, are very restricted. Yes, they're a step forward from the previous ones, but a lot's changed in 2013. We still can't stick to the same rules and then expect GPs to change, but stop, or close all the doors and say, but you can't change this, that will stop you from doing this, and so on and so forth. Absolutely. You're saying that, what I'm saying is, those are the kind of barriers that we want them to remove, and those are the things we made a case forward to try to address. Whether that will come out in the new lot of PCDs or taking part of the wider premises conversation depends on how much we can get agreement on those different principles. Not necessarily about what the problem is, but what's the potential solution. And it wouldn't surprise you to think that we do look at certain things differently in terms of how I look at it and my colleagues in the premises team and how NHS England look at the same thing. But what we can get agreement on, we want to get that out quickly so that the ETJ funds can be spent on improving the premises. What we can't, we will have to cover in the wider premises commission, where it needs to be a fundamental conversation. It's not just about a set of rules, about what is our vision for this. And general practice is changing so quickly. Every time we're coming up with something, it's already 1 or 2 years behind. It's got to be a lot quicker than the things are happening.
One of the things that I've seen is certainly with our community trusts and our acute trusts, they obviously use the GPs and the GP element of premises within sort of big centres, obviously as a cheap way of them delivering services So I work in a centre where there are rooms available to be hired, to be paid for, to deliver clinical services. But actually the acute trust won't use them, or the community trust won't use them, but they'd much rather be in the GP room because they won't cost them anything to be in the GP rooms. So to me, it almost feels like actually we're using general practice primary care funding, which is already below the levels we want it to be anyway, to subsidise actually again the delivery of acute and secondary care type services. To me, that just feels wrong.
It doesn't make sense at all, does it? And it doesn't necessarily mean the rhetoric of having general practice at the centre and everything else built around it, rather than still the age-old notion of the big shiny building at the centre, and then everything else fits around it, and we'll use the rest to deliver what we need to deliver. That's a challenge nationally and locally, I'm sure, where you constantly have to have this conversation with NHS England and CCGs to say, whilst you're saying it, you kind of need to deliver that in real terms, rather than just simply having a set of words that reflect the general practices at the centre of something that you don't know what the something is.
Because these tend to be large organisations that have got premises expenses built into their contracts.
Absolutely. No, agree. Yeah.
Craig, on that top one, 100% improvement grant, currently it's the value of the sum of the money you get which dictates the rent abatement period, whether it's going to be 5 years or 10 years. Yeah. So I'm not too worried about the 100%. Other than, is there discussions in there that if you get 100%, you may never get notional rent or cost rent in the future, or will it defer for 10 years? What's the arrangement?
So, I want to take these one out and say we're in negotiations, but the fact is, you are right, the percentage of it is irrelevant to some extent. But what used to be the case before was if you had a project which cost you £100,000, you will only get 66. So if the improvement costs 100,000, you'll only get 66,000 pounds. You have to find it in the before. But what we get into a position is to say, if you need 100,000 to improve your premises, you will get 100,000 as long as it meets criteria and so on and so forth. But the abatement has to reflect the funding that's been on offer then and offer now. And we'd be silly to agree on something which is worse than what it was before. So if we want something better, we want to be pushing for something better than what's in the 2013 corrections.
Because the difference for us as a practice, my practice, we were asking for an improvement grant, the value we wanted, and it's an NHS person who came along and said, if you ask for 2,000 less, your rent payment will be 5 years instead of 10 years. Which the partners at that point said, well, chip for another 2,000 and start getting rent. So we need that kind of information to make that decision on what's in our interest.
In the new directions, those bands, as well as when their abatement finishes, will all be reflected into that. And obviously we're going to trade certain bits in it, but the way it's going to be is looking at what the maximum amount of projects are, the band of where it's going to be, is we want them to have the biggest benefit without compromising the other costs. So yeah, that's the kind of stuff we're looking at the moment. But again, from referrals, I'm not sure how much of a problem it is in Northwest and Manchester. So everybody do upfront referrals. Or choose and look, always look how it does. This is really varied. It does depend on which part of the country you're in and what kind of systems you have in place. But I'll be one of those that put my hand up. I have no shame in admitting this. I've never done a paper referral in general practice. Although I haven't done electronic referrals either. My secretaries do everything, and I just say to the patient, we'll refer you, that's it. So I just dictate a letter, it just happens. I don't even know what the process involved is. Having said that, when I took on the job in homicide, one of the practices asked me to say, come in and have a look at how our system works. I was one of the few, has anybody here been to Hull? City of Culture, come on. If you haven't, if you haven't, Hull has a unique problem called Kingston Communication. The only part of the country that doesn't have BT. BT can't even come there. So even Sky can't have broadband, it's only KCOM. And when this practice asked me to go and have a look, and they choose and book thing, and you click the button, remember in the dial-up days, you used to have the wheel that goes round and round and round. And the wheel starts turning. You can go make yourself a cup of coffee, go to the loo, come back, and the wheel's still turning. I'm like, wow. Then you realise if it's taking you 10 minutes to do each choose and book referral, no wonder some people don't want to do it. And if you go and refer a patient in, and you've got no appointments to put them in, you've got no information to send to the patient, and if you've got no system that's actually fit for purpose, I'll use another example. When you do a paper referral, you dictate a letter, you put it in an envelope and you post it, and that's it, that's your responsibility done. Yes, there are caveats. If you're worried about something, you fax and you check. Otherwise, if the patient haven't heard anything, you check again in a couple of weeks. You have systems that work for you in your practices. What happens for an electronic referral that you click a button in your practice and it goes, but it doesn't get to the other end where they actually process the referrals? Who's actually liable for that? If the patients get delayed in those kinds of scenarios. There are fundamental questions this whole process brings that still need to be addressed. And I'm sure 20 years ago when we moved away from the Lloyd George files to, when we moved away from the Lloyd George notes to computer records for patients, I'm sure similar concerns were addressed, and I'm sure there were similar problems around that time with the computers not working necessarily and initial teething problems. I think this is a direction of travel that is happening. We're looking at the stats. More than 80% of the referrals are done electronically now, so most GPs and GP practices have brought onto it. But there are significant places that have significant issues, not least because of connectivities, but all the other procedural problems. What will happen if there's another cyber attack? How do you deal with it if there isn't a backup system in place and the only way you can do it is by your computers and the computers aren't functioning? What happens when the internet connection's down? Then what do you do? Our systems operate without internet, because they can do offline, but if it doesn't work, what's the solution? So we've set a set of principles to say, for electronic referrals, because for hospitals it's contractual, they won't get paid unless they receive it electronically. But from our point of view, it's not really GPC's job to tell hospitals what they should be doing or not. But from our end, if you want GPs to use a system, it's got to meet all those principles. You have to have a system that actually works. You have to have the LMC and local GPs at the centre of it, whereby you discuss how these processes will work, rather than simply coming up with a scheme and just impose it on GPs and say, this is how you're going to do it. It doesn't matter if it works for you or not, but this is how you're going to do it, because it works in secondary care. So those are the kind of things that we don't like and we don't want to see. And like I mentioned earlier on, one of the other big things is that we are working on some guidance that's going to come out relatively soon about the liabilities and the new challenges that electronic referrals will bring into general practice. We've already had cases where a patient turned up to an appointment in hospital and they were told that, oh, your appointment was cancelled, did your GP not tell you? Well, GP didn't know either. Those kind of things will happen. But we can't have those things happening, especially if that results in a negative outcome for a patient who will be held responsible. And again, what's the flavour, what's the mood in the room about electronic referrals normally? Do you love it?
Tends to work. We've got the appointments and the system, you can track and trace it.
Yeah, that certainly is a positive experience for about 80% of GPs, but I think where there are connectivity issues and that things like referral management processes that don't seem to make sense, there are some objections to it. But it's those where you get the processes right by involving GPs and LMCs locally to come up with a process that works for everyone, it'll work. If they don't, it won't.
One of the challenges we've got, Commissioner, is that it's the change processes. It'd be fine if it was just paper. It'd be fine if it was just fax. What we've now got is a very mixed economy, where if we take 2-week waits, which is probably the most important, some of them have to be done using ERS. In our case in Thameside, I think it's breast, lung, and I can't remember what the third one is. There's a third one that has to be done using ERS. The others are emailed to an email account. And it's the mixed economy, and it's the fact that one week it changes to another, and there doesn't appear to be a very simple place that you can go to find out what to do. And the fear is that things are going to get lost. I don't know if others have got, I don't know what's happening in Oldham.
Well, it's the same challenges up and down the country, and I'll be entirely honest with you, even in our practice, what we've asked the commissioners and to say is to sign a document with us to say that any new electronic things that you're going to be coming up with, whatever it is, whether it's referral, results, whatever it is, they have to be systems that are interoperable with one another. Don't give us 10 different logins and 10 different systems that you have to do this for this referral, that for that investigation, and something else.
And the fear, like you said, is that we're a doctor, we're making the clinical decision to refer. What we should have is if you haven't used the right referral system, that the provider just rejects it because you've not filled out this form or whatever it is. Because at some point, someone's got to look at where's the patient risk.
Yeah. Oh, absolutely. Well, that's the kind of thing we want to cover in the guidance as well. So where it is simple. I use a musculoskeletal example, certainly where I work, where I don't have to request an investigation or refer them to an orthopedic surgeon. I just send a referral to MSK Health. They do physio if that's what they needed. They request an MRI. and if following that, if that needs an orthopedic opinion, they will refer the patient on. For my end, it's great. Just one click for any MSK problem, and that's dealt with. Why would I not want to use it? But if there was a system that says you refer to MSK, and if that person needs an MRI, you then get it back, you fill another form, send it off, that refers to an orthopedic referral, that comes back to you, then you send off another referral. So I'm not going to use it. Simple as I'll just refer straight to orthopedics and say, you sort that. So that was developed with local GPs. So if you come up with a system that works from our end, and it makes their end better for them, let's use it. And if it's uniform, it's not one solution for one and a different solution for another, and like I said, 10 different logins and 10 different forms, then it is going to fall apart. So I think people need to address, as the commissioners and the boards need to look at these issues and think, what's the best way of engaging GPs in this kind of processes? If you deliver on all of those, most people look at the make our jobs easier. If you don't deliver on all of those, surprise, surprise, we won't. But what we have acknowledged and what we're pushing for in the contract negotiations is this will put a burden on some practices with respect to finances. So it will have financial implications. So we are seeking to get some recompense for practices where you have to move in this journey. I've told you how much money is available in the allocation itself this year, but we're trying to push for that to get some funding to really promote use of upfront referrals where all this criteria is met, where it is actually better for practices. Sorry, do you have this? Sorry.
Our problem is that Greater Manchester's pushing forward on this, and all but one of our secondary care providers is adopting this from the 1st of April. Some have already adopted it. You've got on that slide some issues that we were raising at a meeting with our local CCG today, and their view was one of sort of resigned acceptance, I think was the best way of putting it. And because it had come from the top and it had come through Manchester, and they didn't really put anything forward in terms of safety net. What happens with the failures? I mean, I suppose Manchester's pushing ahead because most people have probably got broadband, unlike some rural areas where they probably haven't got it at all. I have no idea what's going to happen out there. Did you want to add anything to that, Zubin? Because you were at the same meeting.
Yeah, I think part of the issue is for each area, it's where you are with using ERS already. So on our patch, I mean, we were probably about 98-99% anyway, so therefore it's not going to be a massive change. So the issue for us is the contingency plan for those exceptional kinds of circumstances when something goes wrong. The thing I found interesting in that conversation was, because I put it to them that actually, as the Commissioner, if you're putting these pathways in place and therefore you're mandating this is what you want us to do, if there is a complaint or a problem, then obviously we will be directing these people to you. And their view was, that's fine, because we'll be directing them to NHS England.
That's helpful. I mean, this is where I think where the LMCs will have to use the strength to try and push back on some of this nonsense. Because at the end of the day, if they want a system that works for everybody, you can either do it through collaboration, winning hearts and minds with colleagues, or impose something that's daft, that's not going to work, which will break and which will cause them problems. If they don't recognize that by doing it the right way will actually help them and doing it the wrong way will get things wrong for them, they are asking for trouble. They're asking for trouble. I think from our end, all we can do is the right thing to refer the patient appropriately with the appropriate means and appropriate facilities that we have in place. And if they're closing off avenues and say we're not accepting this referral for this patient who's unwell because you've not ticked the right box, that's the kind of stuff we need to cover in the document and say who's then liable to make that call. And another part of it, whilst there's a tension between primary and secondary care in certain cases, there's also the facilitation of a positive way of working. When a consultant receives a letter that's got clear enough information about a patient, it's very difficult for them to say, I'm not going to see this patient because you're not taking the box. So I think those kind of positive relationships will help. But hopefully when this document comes out, it will answer some more of those questions. But if you are getting these queries and you're getting pushback from the CCGs locally or from NHS England, do let us know. Let your LMCs know, let your regional representatives and GPC know, and we will flag it up nationally. So it's one of those options where you do have, and we've got to fight the battles at all different levels for some of these initiatives, and we will.
But what about onward referrals?
Onward referrals?
Yeah, so for instance, if you refer a patient to audiology for microsuction of wax, and the patient complains they've got some hearing loss or they've got some, vertigo,
their sort of protocol at the moment is to refer back to the GP, so for us to then refer them back into
Well, the
ENT.
standard contract changes in 16, 17 and 17 to 19. I've got a very good set of wording about that one. In fact, we've got agreement locally as well. If it's related to the original problem that you have referred them to, it is the secondary care's responsibility to forward refer it on to them. But if it's an unrelated condition, somebody's referred in for knee pain and they've also complained of headache, it'd be reasonable for them to say to the GP, look, this patient's also got headache, which you might have to look. So I think those kind of things, the BMA template letters and quality first are the ones to use to push back on that one. And hopefully, when they start receiving the template letters, they are a nuisance for CCGs to get those letters as well. Because we've included in our letters that we use in our patch to say, and we look forward to your response, that one sentence. So it's not just a notification, we're actually asking you to respond to that. That will change practice. Can you state more? Yes, I'm running out, sorry.
I know this is about hospitals, but I wonder whether we can tie community referrals as well. In my patch, believe it or not, there's 18 different AQP ultrasound scan providers.
Wow.
Yeah. And believe it or not, the CCG actually sent the referral forms for all 18 to GP practices with the suggestion that we should have a discussion with the patient on which service provider we should use. Now I got asked, and I said to the practices to get one or two, which the partners, the GPs are comfortable with, and just keep those referrals. But they've not even gone as far as saying, let's have one standard referral form for all 18. So somewhere we need the referral form sorted out, but also we need some common sense brought into the NHS about how many AQP providers do you need in one borough before it becomes so.
Yeah, I can't talk that one. That's the worst one I've had. I've had 2 or 3 providers in certain places and think, why the hell have we got that many? But yeah, I understand where you're coming from on that one. I mean, that's the kind of conversations that happen with CCGs and think, really, come on.
But it's not just the CCGs, it's a national issue.
Yeah.
As soon as AQPs come down, the CCGs put their hands up and say, well, they've applied, they've fulfilled the criteria, we have to approve them. So I think we need a top-down approach.
Okay, so we'll take that back, absolutely. Just have one last comment.
Well, in a way, it was a link between the last two problems. Because one of the issues seems to be, I'll take the audiology example, that often it is an AQP provider, and it seems that all they can do is refer back to the GP and not refer on.
Sure. So the onward referrals for the non-standard care parts of it, so community services and other diagnostics and so on and so forth. Yeah, right. We'll take it over back. It's one of those things, the anti-standard contract only applies to certain sets of organisations. If it's an AQP, it certainly doesn't. But that's next. Right. Let's add this to the pile of the next lot.
Yeah, interestingly, on our patch, spec savers through the minor eye condition service can refer directly to ophthalmology, informing the GP that we've done a referral. That's part of the NHS service.
CCG, yeah. No, fair point. We'll take that back. I mean, that's the kind of contractual stuff that we're dealing with at the moment. And if it's okay with you, just focus on the same general practice document that we produced, which is looking at the key areas that we want to try and get some movement on and find some realistic solutions. It's about the funding, which needs to be recurrent and sustainable for general practice, a realistic workforce strategy that doesn't focus simply on workforce substitution, but on workforce expansion, trying to address the long-term indemnity package situation, which obviously there's already been acknowledgement from the government and we have got some movement on, and looking at workload, which is one of those things which we are more in control of than anybody else. It's not something that others can do for us. We have to take charge of the situation, but clearly there are certain things that will help us control our workload. And the last 2 things, which wouldn't surprise any of you, is that we do believe in having a national core contract that's negotiated nationally that gives us the stability and sustainability to invest in our premises and in our practices to look after our patients better. And also working on IT and premises aspects as well, which needs to be a sustainable thing rather than not investing in something for 15 years and suddenly coming up with £1 billion and putting in so many barriers for you to access that pot of money. It doesn't actually make it realistic. So going into detail into those, so looking at the funding aspects, going into the funding access, we know for a fact that there has been a significant investment in general practice over the last few years. Couple that with increasing workload and demand is essentially why we are where we are, which is a crisis in general practice where everything is going in the wrong direction. And what we do want to be doing is use this document. Again, if you haven't come across this, it's on the BMA website, it's not behind any firewalls or anything like that. Please do access it, please do read it. When you are having local conversations, whether it's your commissioners, NHS England, members of Parliament, other stakeholders, take a copy of that with you, and then ask them to look, these are the kind of things we need for general practice. When somebody says, why is my constituent having to wait for 4 weeks in their GP practice, these are the reasons why they're having to. And guess what? This is not just a problem paper, this has the solutions. So go to Parliament and ask the Secretary of State, ask the government what they're doing about getting general practice out of the whole of the food. But this has all those aspects in it. And it is no surprise, and this is roughly the year when I remember at a conference we asked the Secretary of State, has general practice hit rock bottom, or is it likely to get worse? So whichever one he picked, he was going to get into trouble. Looking at the funding status itself, it looks like rock bottom for the 2013-14. This is purely on funding, not the workload and everything else. And the indication is that number is now going in the right direction. And the projection for the next few years based on the primary care allocations for CCGs is that the funding for general practice will increase to about 8.5% in 2021. Not nowhere near what is actually needed, and the next slide will actually show the deficit that we've already got. So looking at the funding for 2016-17 and projection for 2021, every year there's a £3.5 billion worth of deficit of funding that's going towards general practice. Whilst the government committed to 2.5 billion recurrent funding by 2020 in the forward view announcement, the reality is that over a 5-year period, if we're losing over 3 billion every year, that's 15 billion pounds worth of funding deficit we just simply can't catch up with. That's not a small amount of money, that's not cost that we can absorb and still continue to do everything to the highest standards, to more and more people with more and more health needs in region. And that coupled with potential issues with workforce. I'll show you some numbers later on. But like I mentioned earlier on, Amy mentioned it and I talked about it as well, all the numbers were going in the wrong direction. And until very recently, there hasn't been a commitment from Health Education England or NHS England or the government to try and really invest into this area to try and address the problem. But we have made some progress. We made quite a few big steps, none of which on their own is enough to address the problem that we're in. Medical school expansion, we've been saying this for a decade. So we need more doctors across the board. We need more doctors choosing general practice. For the first time now, 12 months ago, the Secretary of State announced that he is going to commission extra medical school places with a focus on general practice as well as mental health and public health and so on as well. And talking about that enhanced recruitment scheme, unfortunately Manchester won't benefit a great deal from that because these are really focused at rural areas who are struggling with recruitment at a significant level. When we said you need to incentivize trainees to go and work in some of these rural areas, some of these areas are beautiful, you just never go there because most people are interested in living in cities and working around the cities. But if you incentivize people to go and work in these beautiful places, they may actually decide to stay there. So GPs may not have to deal with 5,000 patients per head in some parts of the country. So they've come up with the incentive scheme of £20,000 for GP training to work in these targeted recruitment areas. Initially there was only a handful, and we said it would work. They've tried it, it's worked well. The Secretary said increase the number to 200, and HE have even top funded them at another 56. So there's 256, that's roughly 8% of GP trainees in the country will be incentivized to go and work in remote and rural areas where they have significant recruitment areas. The principle being that when they work in there and they fall in love with the place, fall in love with general practice and there, they'll stay on. That does not address the fact that we haven't got enough GPs across the country. And somebody made the point to say, well, we need that across the country because we don't have enough GPs anywhere. That's absolutely true, but that was more of a relative thing where GPs tend to be now focusing more on the bigger cities and the rural areas are suffering even worse than other parts. We also got things like the induction and refresher scheme. Until recently, if you're a GP who left NHS for more than a year or more than 2 years, the way for you to get back onto it, especially due to the bureaucracy of the performance list, was an absolute nightmare. You've got no chance. If you left it, you left for good. It's nigh impossible to get back on it. We've been able to standardize the processes and implement the process, which isn't perfect. It's still bureaucratic, but at least it's bureaucratic across the board. So you can still get back in. It'll take you just as long as it's within Manchester as it'll take in Liverpool or in Newcastle. But there's now a process, there's now a method, there's some funding behind it to get GPs back into the profession. There's a new GP retention scheme, which is, again, it has been in existence for a while, but the funding wasn't enough. We managed to secure some uplifts to that. So if you're a GP and want to be part of the retained scheme, the practice will receive £4,000 per session to keep you on the retained scheme, and the individual GP will get £1,000 on top of the salary that they'll get for the practice. Those are the kind of things we need to focus on, particularly the older GPs. And I say this with absolutely no qualms at all. For anybody who's over 55 who's retiring, you're going to need 2 or 3 newly qualified GPs to replace the work that they're doing. So the best way of improving the GP workforce crisis is by retaining the experienced GPs that you've got. Stop them from retiring or something. Right? Yeah. Well, incentivize them to stay in practice so that it makes your job easier about recruiting GPs into it. So those are the kind of initiatives we need to look at. And yes, there is a controversial one while we're trying to import GPs from the rest of the world. We've been conscious of not going to places where they have even fewer doctors than we do and say, but look, we'll pay you a lot of money, come and work in the NHS. That's not the principle that we wanted to see. We wanted to offer it to particularly European countries where the numbers aren't as bad as ours, they're probably a little bit better than ours, who have an interest in coming and working in UK general practice and remaining in here. But let's not go to parts of the world where they're struggling with healthcare even more than we do, but just because we're the fifth richest nation in the world that we can just throw money at the problem and solve it. But that doesn't solve it. We do have a responsibility for those kind of things. But there are other things like clinical pharmacy scheme. I mean, I say this so many times, and I'm happy saying this in this room as well. When we negotiated that 3 years ago, the funding for that was very limited. It's still very limited. You get 60% of that funded the first year, 40% the second year, 20% the third year, and nothing for 4 and 5 years. The objective or the idea of that scheme was it's a substitution. We can't get enough GPs, but there's some way to get a pharmacist in, so the pharmacist can do all the medical work, all the prescription work, and that kind of work that you don't necessarily need an extra GP, and the clinical work can be shared between them. When that came into place, I stood up in GPC and said, this isn't necessarily great funding, it's not recurrent, it's not sustainable. And I made that point to NHS England, and hopefully nobody will engage with it. And then we can go back and ask for better funding and a better scheme. It's oversubscribed 5-fold every single time. So if I make one request to you, don't be enthusiastic all the time. Push back on something. If it doesn't feel right, if the funding isn't right, don't necessarily go for it. In a way, I was sat there thinking, I really hope nobody applies to this and we can go back and negotiate it. When it's oversubscribed 5-fold, I've got no grounds to go back and ask for better funding or a better model. Every single time this comes up, it's oversubscribed. But it's worked in some places. Pharmacists are, the right trained pharmacists in the right setting are a great asset. I've spoken to many practices who use clinical pharmacists and they can't stop singing praises about their pharmacists. We've got one in our practice now too. It's fantastic. But funding isn't sustainable. What we need is not substitution, but expansion of the workforce, and we need to focus on those kind of solutions where we get more. And again, that's not a surprise. Every single year.
Just one of the issues that one of our local GPs has raised is that the pharmacy funding seems to be coming from different pots of money. So therefore, what happens is you've got different employers employing pharmacists to work in the same GP population. So one of our local practices has actually got 4 different pharmacists working in the same practice.
They're part of 4 different bits.
And the issue really is that, wouldn't it be so much better if the money was actually given to the practice so they could employ one pharmacist to do the same work?
Yeah.
But that's not what's on the table.
No, that's not what's on the table at all. I mean, Northern Ireland, this chair of Northern Ireland GPC really does, he has put a pass around on this one. They've got a scheme where an average GP practice in Northern Ireland gets 1 full-time pharmacist, fully funded with indemnity and everything else, full stop, no strings attached. That's what we wanted. That's what Tom and I, we were working on workforce together at that time. Tom got it and I ended up with this. And it's still very popular, and I can't get made it any better because it's still too popular. Which is why I've made the request that when you look at something and it doesn't look that right, don't engage with it. And that's the problem with it. And if a practice can be part of 5 different bits in the same region and get a quarter of the pharmacists there and a quarter of the pharmacists there and so on and so forth, it's utter nonsense. If Northern Ireland, with all due respect to our colleagues over there, they don't even have a government. They haven't had one for a year. I mean, they have got £1 billion extra money, which is obviously working in their favour. But if they can come with that, come on, we should be able to do something better. Unfortunately, because of the over-interest in the scheme, the chance of us securing any more funding on that is nigh impossible. We just haven't got the argument to say you need better funding for this one. But what we're moving away from is therefore not about that scheme, but a true genuine expansion of the general practice workforce to deal with the increased workload, not just about the workforce issues.
But how much of the oversubscription is because of the desperation of practices?
Yeah.
I mean, that's
most
the issue.
of it, I
It's
suspect
not
it
the
is.
funding, it's the issue of, needs must.
Yeah, absolutely. I suspect it is. But from their point of view, they say, you need to fund this better so that GP practice can really benefit from it. They're argument would be, no, they're already benefiting from it for this low level of funding. I'm not saying we're our worst enemies by any means, but it's one of those things where, yes, we are desperate and we will put our hand up and say we'll engage with that. That sometimes works for us and that sometimes doesn't work for us. And this is one of those examples where it's made our job a little bit more difficult to try and get better funding for it.
So on the same issue,
Yeah.
my practice, we didn't actually sign up for the pharmacist because clearly we didn't think it was sustainable. It was attractive probably for the first, maybe the second year, but then the reality was I felt that we would have made this person redundant. And I suspect then, to some extent, that's when your window of opportunity will arise when some of these pharmacists start becoming redundant again, because the practices won't be able to retain them.
Yeah, well, completely. I mean, I remember colleagues from Norfolk LMC as well around that time asking me when is this going to come out. And when it came out, I did let them know that this is what it is. No thanks, we're going to do our own thing. Whether fully employed them by themselves, whether pick the pharmacists that they wanted to deliver the things that they want after their practice. So absolutely take on board. I'm with you on this one. But it's one of those where we need to push back and try and get more rather than take the first offer that's on the table, which will actually count against this. In empty packaging, I'm not going to cover too much of that. I've already said enough. I think that our principle is about getting a fully comprehensive empty package to cover all staff within a GB practice. That should come into place in April 19. We're looking close to about this. The workload one, which is what we talked about slightly briefly earlier on as well, there's a lot of work going on this. Those of you coming to the LMC conference, there's a theme debate as well happening there about the new workload paper that Brian Balmer has written for GPC, which we want to discuss. Part of this is in our control, part of this is completely not in our control. There's absolutely nothing we can do about how many people will come to the practice doors or ring the practice asking for help. There's certain programs at G4 we have put in place, like the Practice Resilience Scheme, that has helped some practices overcome specific problems in the short term, but that's not sustainable funding. It's already dropped by half within 1 year, and next year there really isn't any commitment for more resilient funds at this stage. But there's got to be something where we can say the practices can define what is a safe limit. What is the point where we say we can't do any more beyond this? We can all remember a day where you think, I have seen so many patients today that if you ask me what the last patient came in with, I can't actually remember. Who can remember that? Yeah. We've all had those. And literally walk out the door thinking, I don't know how many people I've done right and how many people have done wrong. I have no idea, full stop. That can't be the norm. And those days are becoming more and more frequent, where it may be the one day where 2 members are on leave and one suddenly is off sick and the computers are down and suddenly you have a bad day. But that was the exception. That's now becoming the norm in most places, especially Mondays. Who works on a Monday in clinical practice? Yeah, who hates working Mondays? Yes. There's no stop to it. It's one of those things where we need to be able to say, that's my limit, I need to stop. But what happens then when you do stop? Who then takes on the extra workload? How do we manage that? How do we have that wider conversation? And how do we find ourselves time by reducing the bureaucracy and duplication of the amounts of processes that we have to do for our patient? Where you see a patient, like Mo was saying earlier on, if you have to discuss with them that there's 18 different people who've been in ultrasound for you, which one would you like? And let me tell you about the 18 of them. Really? Is that the kind of stuff that we need to be spending our time on? So we made it very clear about there are things that need to happen. And go to the next slide. And the paper that we're discussing and some of the initiatives that we have done will address some of those. Has anyone seen this leaflet? You haven't. It's a leaflet that's developed by the BMA, Antis England, and National Association of Patient Safety. I know it's not transposed on here very well, but if you do go to the BMA website, and Quality First, that's there in that Quality First website. I love that leaflet. On the top right there, on the left even, there's a checklist. So this is the leaflet that you give patients. And when I say it's developed by the BMA, by the hospital doctors and GPs, that checklist says when you're in hospital, do you need a signal, and as your hospital doctor giving you the signal that you need? Do you need a prescription for the medication? Do you have appropriate arrangements for follow-up? Do you know who to contact, what needs to happen if something doesn't happen that's supposed to have happened, and so on? That is, Kent LMC had their own version of it, and we used that to build on that. It is a great leaflet where you give them, it is not the practice's responsibility, it's not your document that you produce. There is no liability attached with it. It's a nationally developed leaflet. Give it to the patient. Stop inappropriate things coming back your own way. Empower them to go to their hospital appointments with the right information in front of them and say, and if England says, it's your responsibility. So can I have my signal that I need now? And can I have my prescription that I need now? If you want hard copies of that, every practice was supposed to get 200 printed out. How many of you got it? Yeah, I thought so. No. Exactly. But please do go on the BMA website, BMA Quality First. These leaflets are there, you can download them, print them out in your own practice and start using them. You don't even need to touch a word on it, it's all done for you.
Chris, just on the last slide.
Sure.
The last one. The one before that. You said, in the solution bit, it says practices to define capacity limits. At the moment, irrespective of whatever we define, if the commissioner says, no, you're not closing your list, we get into a conflict situation.
Yeah.
And I just wonder whether nationally, and I accept that this could be a carrot and a stick, in that if nationally it was defined that so many patients registered for whole-time equivalent GP is reaching a kind of a threshold, we could go back to a commissioner at that point and say, look, we've got national support that we can close our list. We don't need your formal approval.
I'd phrase it slightly differently, but the reason I say that is, I've recently been to a practice who was struggling, and we're talking about the solutions that they have about how to control things. And I said, why don't you close your list? I said, I don't want to close my list. Getting more patients will mean I get more resources to do different things. I get that. That's one way of looking at it. And you, as I actually get more in your camp than the other camp. If you're struggling, you don't want more money and more work. You just want less work. That's priority. But not everyone looks at it that way. But the caveat I always say to that is, if the CCG doesn't approve a formal list closure, stop accepting patient registrations. Don't close your list. GMS regulations are very clear that you can stop accepting patient registrations as long as it's done in a non-discriminatory way. You don't have to close your list.
Well, we've had one practice that CCG's issued a breach notice because they did exactly that.
Again, I would want to look at those documents and see on what grounds they actually said they were breaching the contract. But regulations are very clear about stop accepting patient registrations with safety concerns. And I think one of the things that also help now is a recent letter. I know GMC is not the flavour for us here, but at this point in time, there's an email from Terence Stevenson that came out about 3 weeks ago, which talked about informing GMC of situations where people are being put in pressure to work under pressure situations. So if the CCG, they may have tried to pull that faster than before, if the CCG is trying to say that you cannot do that, despite you having safety concerns about what you can deliver for your patients, GMC have now given us a new tool to say if you're being put in that position, the GMC wants to know. CCGs are still clinically led organizations. I'm not saying go and grasp a new CCG, I prefer them all to GMC. Collaborative working and finding a solution is always the best way. But if somebody's being so difficult and can't understand that a practice wants to close their list on grounds of safety, and they're making you then take the responsibility of operating in an unsafe way, what other option do you have? But going on to the conversation that's going to happen in the next one here. Next one, yes. Oh, yeah. And the last one we're looking at is in this document that we're going to be discussing in the GPC conference is the notion of black alerts. Who hasn't received an email from a hospital to say, please don't refer patients, we're full? Yeah. Imagine if we send a communication back to the hospital and say, please don't discharge patients because we're full. Yeah, I mean, that won't work. But in the same way that hospitals have the provision to say, we are at capacity, we can't deal with it anymore, we need the rest of the system to support us, we should be able to do the same. But whilst it's easier to said than done at a principle level, say we should be able to say, I'll raise a black alert, but there needs to be a process as to how we do that and what support systems that are then in place. And if you raise that alert and you inform the board, inform NHS, inform CCG, then the onus is on them to say, well, practices are struggling, there needs to be done something differently. Same when the hospitals are struggling, they cancel the whole elective work for most of December and January coming into February for most places. How many times have we been allowed to close all of our appointments just to deal with emergency? Imagine if you even tried to do that. Yeah. But there's got to be processes that GPs at an individual level, practice level, perhaps at a locality level or a CCG level, be able to say, we're done. We can't physically see any more patients because it's unsafe.
I had a very interesting experience recently about other organisational perceptions. And it was very much, well, as long as their needs were satisfied, that was fine. And it was basically, one of our patients had run 111. They diversity 999. Paramedics had been so the paramedics had been and assessed them, and they said this patient needs a GP appointment. And being at capacity said, you can have a GP appointment, but we'd have to cancel a visit on a terminally ill patient if we do that. Is that acceptable to you? And it was.
Okay.
Fortunately, the patient was okay about the other one, but I just felt, for them to view that, someone who'd already been seen versus someone who hadn't, I thought, Yeah, they just basically want to tick their own boxes, but there's no global, there's no wider perspective about it.
Yeah, perceptions and I think one of the paradoxes with that one is also that people talk about improving access solves the problem. I'm not sold on that. I think improving access may address some of the problems for some of the people. If you make something so much easier to do, people will do it more. I mean, I use my own personal example. How many of us used to say 15 years ago, check our bank balance every day? Not that there was a lot in it, but how many of you would go to the cash machine every single day to check your bank balance? How much in your current account? How many of you now on your smartphone, I just have a look. I don't want to spend anything in the last 2 hours, but I just have a look. I'll get something for $1,000. So if you improve access to something, you end up using it a little bit more. There's need, absolutely, but if you make it so easy, then people are like, yeah. I mean, we operated a system where we're doing telephone trial of every single patient, acute and chronic care. And I still remember the call when somebody rang me and said, I've been constipated for 2 hours. I just wanted to ask, how frequently do you normally open your bowels account? 2 hours to be constipated? Because you made access so easy, all he said was, whatever problem you have, ring us, we'll sort it out on the day. And this chap genuinely felt not opening his mouth for 2 hours was a problem. To ring us at 8:15 in the morning. So I think whilst, yes, there are places where access will help, and this notion of making it so easy people think it's all about me and not nobody else, will actually cause a problem. I couldn't agree with that more.
Chris, do you think this will only work though if there's some sort of national legislation to back practices up? Because all of these things I think are absolutely fine, but there's still no onus on the consumer to take responsibility. It's all about us as the providers finding ways of dealing with the consumer demand. There's still nothing nationally, legislatively dealing with the relentless consumer demand.
Absolutely. And I think that's the kind of challenge that the whole health service has, but we have a particularly difficult one. You've got the commissioner, provider, and the consumer, and the three bits to it. Solutions for work will only happen when all those three are lined up perfectly. Although I wouldn't say that they're certainly lined up in secondary care, but there's a system in secondary care when it's getting too much, it gets alerted, don't go to A&E. The posters are there about not going to A&E, up and down the country, on the buses, on the TVs, everywhere else. Well, don't go to GPs isn't there. I'm not saying nobody should attend their GP, but self-care, using other aspects like pharmacists, and how many people go to the chemist now with a cold? No, they don't, they just come straight to GP. Those are the kind of things we need to be directing in different ways so that we can manage the workload. Whilst that's one part of it, patient education absolutely has to. But the third thing is, from who I represent and who we all are discussing about today, is GPs taking ownership of some of that problem ourselves. Unless we say, that's enough, I'm not doing beyond that. You can't do that on your own. You need to be empowered. Like you said, absolutely, there's got to be national level conversations and protections for GPs and practices and locality levels to do that. But unless all those three are lined up, getting two of them sorted and expecting the third to just fall into place isn't going to happen. Mo?
I'm just saying what Sam was saying now. The other bit we need is that we can take a stance with patients. Because I had a patient today with 1 week of aches and pains, never had any problems before. And she felt the GP should be the protocol rather than the pharmacy. Now, yes, I can tell her what to go and do and where to go, but the problem comes as soon as that patient wants to complain to NHS England that the GP didn't do something, we're tied up for weeks, if not months, in correspondence. And what we need really at NHS England is somebody who takes a common sense approach to a complaint that comes in and say, forget all the bureaucracy and the paperwork, this is just not realistic, dismiss it.
No. We'll take that back as well. We have
You just glanced over the slide with the GP numbers. GP numbers have dropped, but you've excluded locums. Now, the impression we get is that there's lots and lots and lots of locums out there, lots of new graduates from that going straight into locum and just wanting to locum. So I don't know, is my suspicion right that there's actually probably unqualified GPs but they're not wanting to go into permanent jobs? And is that the biggest issue, is that all those locums that are floating around right in the work need to be insensitised to go and become salaried or partners?
Part of that is, the reason that it's excluded locums is, although we've got the full data set, and I have the numbers from 2004 onwards, the counting of locum GPs has always been difficult for us digitally. So the rest of the data is reliable, locum data is less reliable, And whilst local numbers and salary numbers have stayed the same, it's actually the GP partner numbers that are dropping.
Yeah.
So this notion of there's a whole lot of GPs who are just becoming locums and not becoming partners is, I think, true to some extent. They may start off as local GPs, even when we did the survey ourselves about 18 months ago. Most newly qualified GPs don't want to become partners straight away, but they do want to 5-10 years down the road. I think the problem is that they don't necessarily feel prepared to move from a GP training to salary to partnership for a very good period of time. So that's itself is the issue. But in response to your first question, is the big problem that not enough are going into partnership? Yes. But the second part of that is it because they're all going into locum is not correct. So it's just, there's always been people who went to locum, but they're not getting back into the partnership.
And how many partners are leaving to become locums at the other end?
Yeah, absolutely. And that's another one too. And I'm sure we all know a few. I know them in my CPAT and my surgery who have been partners for 25, 30 years. And they do it in a different way when they're approaching retirement. They want to cut down on some of the bureaucratic stuff for practice management and just still enjoy the clinical work. Which is why I was talking about the retainer scheme later on, where that offers you the provisions to keep that senior partner or somebody who's approaching retirement, but who right now the only option they had is to become a locum to control their workload to some extent. The retainer scheme actually gives you that provision whereby they can remain in your practice but not necessarily take on all the extra stuff and focus on the clinical work. That's still better than not losing them in the workforce entirely. So, okay.
Sorry, another thing we're facing lately is if patients have any symptoms, they'll go and Google it. And then they come in demanding.
Yeah.
I had a patient come in, sat down, I think I've got MS. Why did you say that? I've got all the symptoms.
Yeah.
You know, another one had a headache for 2 days, asking for a scan.
Yeah. I mean,
You know,
I'm probably
increasing
patients
the
and
workload.
sharing information to a certain extent is beneficial for patients, but I mean, I always say to them, if you're going to look at something, look at patient.co.uk, it's less bad than Google. And Google will tell you, if you type in anything with anything together, you'll find something that supports what you think is wrong with you. I haven't got an obvious solution to that apart from shutting down Google, but I'm not sure that that's within my gift or within the government's gift to make that happen. But point taken on. It's about self-care and getting patients to engage with looking after their health in a correct way.
Increasing the workload.
Yes, absolutely. And again, a point I mentioned this point about before, whilst there are new models of general practice developing up and down the country, we firmly believe that they can develop around the GMS contract, around the code actually offering for general practice. You don't need to give up your code contract to become part of something big. Right?
How does this fit in with what we do locally with Devo Bank?
Yeah, I was kind of hoping you would ask me that. Well, look, I think what's happening with Devo Bank is interesting, but certainly I haven't been able to figure out how that would fit in with what the traditional model of general practice while still making it sustainable and grow in a positive way that all of you feel part of. So any kind of new initiatives that way, I would suggest that it's got to be something that's done with local GPs, not done to local GPs. If you're part of the solution and the visions in the Bank about how general practice and primary care can be dealt with, it's something that you all buy into, it's something that you can relate to, it's something that can work in Manchester, great, good luck to you. But if it isn't something that you can all relate to, there's bits of it that you like, bits of it that you don't like. It's like any initiative, any concept where if it's done to you, it won't work. If it's done with you, you're invested in it. Do you either make it work or not? And I'll be again with my hands up and say, I don't know all the answers to what Devo Bank will result in and what it will look like. It's something that we want to look at closely and learn lessons from that, the positive bits and the negative bits going forward. But I'll come on to new models and the ACOs and how that can work towards the end of the presentation if that's okay. But this one, I just want to make the point that we firmly believe you need to retain a core national contract that makes general practice sustainable and stable over a period of time. Yes, we haven't been funded appropriately on the core contract for a long time, but that's a hell of a lot better than being a PMS practice and see 30% of the funding disappear in a 4-year period of time.
I agree with you, but I suppose the question will be actually what is that core contract and what's that contract worth? Because in the context of Devo Bank, etc., obviously more and more of our funding is based on local discretion, and I've got to worry that obviously as the value of the national core contract reduces as a percentage of our kind of turnover, then we could be left with a position where we're actually no longer viable entities should the local commissioning priorities change because of the issues that different areas might face.
I think that makes this even more important, so that GP's contract isn't something that anybody can touch. It's not for anybody else to take away from you, or not that this causes if you breach of contract and so on and so forth. It's your contract. You lose it if you want to lose it. So whilst, yes, the funding for it hasn't been acceptable, and yes, I'll be the first one to say not all the funding that GP practices receive is through the GP's contract. Your enhanced services, cloth and everything else on top of that does need to come in, and you need that for the practice to be sustainable. But whilst that can fluctuate, this is the one thing that doesn't fluctuate. It's the paracetamol of pain relief, where you may be on everything else, but paracetamol always gets rid of that much of pain, it doesn't matter how much pain you've got. So it's that notion of having that stability, where even the other things do fluctuate up and down, it gives you that reliability thing. I know for a fact this is the minimum amount of money that I will get for next year. I think they do it as well.
I agree with you. For most practices, the core contract isn't enough revenue to remain viable. I chair the Fed on my patch, and a healthy relationship with our acute hospital sector has helped my Fed secure a £7.2 million contract for next year. That is small fish for us, considering that same hospital provider is the host provider for the local care organisation.
Sure.
And they're going to be awarded £400 million worth of contracts in the next financial year. So in my mind, the question is, putting the core contract and everything aside, how much of that 400 million in terms of hospital services and other things can we bring back into general practice?
Sure. I'll come to that in the new models of care that we're looking at about the opportunities that we use. And I absolutely agree, those are opportunities, but some are true opportunities and some are things that you think, I will go for that, without necessarily not looking at the risks of that. I'm not talking about this one in particular, but that one we'll cover it towards the end of the presentation.
Can I just ask, just based on that, everyone in the room here, and I guess everyone here is from GM, so the Devo solution. But those who are, how many people still feel the national core contract is relevant as we move forwards?
I'm sure that's great.
So that's quite reassuring.
Yeah.
Is there anyone that doesn't?
I'll leave now, yes.
Is there anyone that
It's more
doesn't?
relevant than it's ever been, as you say. It's the one thing that we can grasp onto, but everything else is changing. We know that that's going to stay, and whilst we've got that, then we know that everything else can change around about it. And absolutely, the money that we get from local commission services is being a much bigger percentage, but still we've at least got that. If we lose that, then potentially we've lost everything.
Okay. Right, so we've got 12 minutes and about 30 slides, so let's see how we go. Does anyone need to go home tonight? I'm not going. Okay, fine. We'll carry on. Now, feel free to walk away anytime we're done. We'll try and go through the rest of it. We talked about this as well, again, premises-wise, it is still a huge thing that we need to be looking at, and I think we made a clear set of demands in our document, the things that we need to get premises and infrastructure back in general practice to level that enables us to incentivize GP practices, recruit GPs to be part of practices, and also deliver a highest level of care that we want to for our patients. Once having said that, there are still things like the PCSE stuff, who's had a good experience with primary care services. I think so. I mean, that has been an absolute nightmare to deal with all of us. We've made it very clear that those are the kind of things that get in the way of us doing our normal job, the kind of things that used to work. We all remember it wasn't perfect before, but it's a hell of a lot better than what it is now. So we need to get back to a system where the support structures around primary care actually enable us to do our job and not act as a barrier. So those are the kind of points we made in that particular section. And nicely moving on to PCSE. We have made it very clear. We've done a survey. In fact, when we sat down to go through, at the last conference in 2017, there was a motion that was essentially talking about the PCSE function to be taken back from and given off to a new organisation. I think the mood at that time from the conference was that let's not have another whole reorganisation of the support function. Let's just give them time to get it fixed. And for about 2 or 3 months afterwards, we didn't get that many queries. I was getting them in my LMC, but there wasn't many on the LMC list server where all the LMCs communicate. And I was thinking, oh, it just must just need my patch. Everyone else has got to figure it out. It's just homicide that's got a problem. So we sat down and we came up with a list of Jeremy and Amy, who's part of our team, came up with a list of things that we thought were pending. And we put it on the LMC list server to say, if there are any other problems, we were not expecting the number of emails we got back. So when we did the survey again this year, Most of the things were just as bad as they were last year, and some were actually worse than they were last year. So we've now started working on a various different set of things that will hopefully enable us to put pressure more on NHS England to get this sorted out. We first of all asked them the fundamental question of, is this happening so badly because you actually contracted inappropriately, or you've given them the right contract but they're so incompetent? So we need to know the answer to that one. But we've also got resources now on the BMA website. If you type in BMA PCSE updates, you'll get to a set of resources where we have now got statutory demands, which are legal documents that have been drafted with BMA law that are on the website that you can send off to NHS England demanding a payment within a time frame, as long as it's not disputed. So if you're not getting payments for things that are relatively straightforward, you send them a statutory demand, they will have to pay you. If they challenge you and say, no, we're not paying you, let us know. That's breaking the law. So if they've got something and they're not acting on it. So there are resources. We're still writing to MPs, lobbying various different organisations, and we've got, I don't know if you've seen a photo, which is the Federation of Ophthalmic Dispensing Opticians. They're also part of primary care. They've got similar concerns with them. Dentists got similar concerns with them. But there's one good thing about PCSE and their deliveries that they're consistent. They consistently go across the board in supporting any of primary care. And we're also sending some access requests to try and understand the situation with the pensions payments for GPs. As well as recently we sat down with the National Audit Office, who are now taking this up seriously. They want to know why things have gone wrong so badly. Anyone remember an organisation that sounds like Capita, just recently gone under? Yeah. And they've had £1 billion worth of their assets essentially wiped off because of the way their organisations can't be run. But for us, it's not, the point isn't about who runs it, whether it's Capita or somebody else who's just as bad. We just want it to work. We just want it to work so that GPs can get the job done. We just don't want it to be a barrier. A GP at hand, has anyone come across and said has this impacted on you? Yes, if not, it probably will soon. This is the new service that Babylon, which is a company in London, has decided to use the out-of-area regulations to try and register patients that they can treat remotely. So the out-of-area regs, which are not great, and we certainly opposed them when they came to GPC a good 4 or 5 years ago, because that would result in cherry picking. Because the regs stipulate as a group of patients that the practice should consider carefully before registering them as out-of-area patients. So those sets of patients, if you read it, it's a really interesting read. Anybody with chronic conditions, if you're pregnant, if you're a child, so anybody who's likely to be unwell will need general practice. Yeah. So you shouldn't register them. So what GP at hand offer is they've taken that list literally and they've stopped all of those patients from registering at their practice, at their service rather, and they open it to everybody else, so essentially everybody who's well, to register their practice, and they offer online appointments, prescriptions remotely, and their list size went up from just under 5,000 to 16,000 in 3 months. Every single practice will have patients you never see. They're the well ones. Funding you receive for them is what helps you look after the patient that you have to see every week. If somebody else picks off all those well patients, you still have to look after the unwell ones. They can't register with GP at hand. Imagine the impact that has on general practice, list-based general practice in local areas. You can understand in certain places online access appointments. These are great things, especially in areas where there's young patients and in university practice and so on. Those are solutions, but abusing a set of regulations to essentially destabilize general practice up and down the country without them actually realizing what they're signing up for. We've had patients who came to practice and said, can I have my repeat prescriptions? Not realizing they've registered themselves in the practice and registered the GP at hand. They weren't informed that when they were accessing GP at hand that they would be registering their own practice. There's also been issues where the app was then pushing them private services through that, through the GP at hand service, which we have flagged up with NHS England. And we've been very robust in saying this is not acceptable, and we have flagged it with NHS England. And Babylon have come up with a comment to say, oh, GPC are being lame and they should be helping everybody do it. So we should help every single practice destabilize everybody else. That's how we all become sustainable, where we all attack one another. They're not the kind of general practice I want to be part of.
Richard, I remember the discussion on the LMC listserv when it originally came out. But since then, I've had concerns from GP practices that may be approached by Babylon to say, can we merge as a partnership and then gradually start taking something over? Has GPC actually sent anything out to practices or through LMCs to guide practices on the potential risks for there? business and their registered list?
Not potential risk to businesses, but we communicated regularly through the LMC updates and GPC newsletter to GPs to say this is something that we have huge concerns about and we have flagged the issues. But see the point you're making, so it's something a different angle to the problem. Whether we can do that with commercial sensitivities or not, but we'll certainly look at it, absolutely. Because I think that's a different angle to it. We've said we don't like this, we have huge concerns, but what you're asking for is to ward off practices from engaging with something.
Well, I'm asking for a practice leaflet that you can circulate to LMCs that will cascade down.
Okay, well, we'll take it back. On GDPR, again, I said briefly, this is the next big thing that's happening to us. There is self-guidance that's being developed that will come out relatively shortly that will help with GP practices. If any of you think the £10 for the subject requests that patients get, we're not getting that is the biggest problem, you've got a bigger surprise coming. I think this is going to fundamentally change how data is processed up and down the country, not let alone NHS or general practice. But this is one of those where we'll start off with a set of guidance that will come out soon. And it'll be a journey that the whole country will be going together. Every single organisation, the LMC, the CCGs, NHS England, everybody has to become GDPR compliant. And it ain't going to happen in May this year where everybody's suddenly compliant. It'll be an iterative process. And then just to top it all off, there's also the UK Data Protection Bill that's currently going through Parliament, which will add another layer on top of GDPR. So yeah, good luck. It's a collective good luck for all of us. I think we'll have to swim through this together and make mistakes and learn as we go along. But we'll try and get the guidance out relatively soon so that companies can have some time to prepare.
But although there's no cost for that for us, we can't charge. We can't charge for this.
I mean,
for data.
The data one, that's one specific one about the £10 that we currently charge, that we can't charge on that one.
But there's nothing stopping me doubling the cost of reports I produce for a solicitor and compensate my expenses that way.
Absolutely. We can't set prices on those. It's up to individual practices. It's how much it costs and how we charge for it. Yeah, it's completely open practice. And the other thing that you may have noticed is, sorry.
Back to GDPR and reports, one discussion I've recently with regards to the amount of letters from solicitors asking for a copy of the notes which they've sent, where patients are not actually realising that the solicitor's getting a copy of, albeit redacted notes, going from when we were born to the current day. When you inform patients of that, suddenly they realise, actually, no, it's due to the car accident that happened, therefore, please ask the go back and do the report. So it's a case of sort of flipping it, it's education for patients as well.
Yeah, and there's a really good resource on the GPC website where it says to clinicians, it doesn't matter what the legal stuff are, you do not share any information with anybody if you don't know why you're sharing it. So if somebody says, the lawyer says, this patient had a headache, tell me about that headache, that's fine, and the patient consent is there. The patient had a headache, tell me what they were doing when they're 2 years old, like, get lost. That's not relevant here at all. Yeah, fair point. The Scottish contract changes, this is obviously a different direction that Scotland decided to go down. Whether it will work or not is something we'll have to see. They're moving away from what we know as the GMS contract to a new contract that's going to come into place in April, and they have voted in favour of it, where they will remove themselves from certain liabilities that we currently have, like the premises, like direct staff employment and so on. And in return, they will get a minimum practitioner income guarantee of 80,430, including the gross contributions. That's a minimum, obviously not a maximum and so on. And over a 25-year period, they're going to be giving up all their premises that are going to be brought up by the board. Now, I don't know, and I'm trust the GPC don't know either, whether that's a solution for England or not. I suspect there isn't going to be one solution for England. We as a group, we're very plural. We all see ourselves slightly differently to one another. We have different visions for our practice and for us individually. Whether we're there in that place where we give up the kind of things that they are giving up there to gain some of the, to lose some of the headaches that we have in return for what's on offer, which is a different way of working. Scots are going ahead with it. They have it in different phases. We'll see how they get on. If they are trailblazers and this is the solution, well, great, like most things, it happens in Scotland first and then we'll learn. And if it doesn't work, then fine, let somebody else make mistakes and we'll learn from those and try not to repeat those. We should make our own mistakes, we should repeat spots. So that's what's happening in Scotland, but we'll keep an eye on that. Hopefully next year when we come back, we'll let you know more about that. This has been, possibly for me, and I'm sure most of you can relate to, the biggest shock in my professional career in the last 20 years. I'm a conflict of interest. I went to medical school with Dr. Balgada, although in different years and so on. But the notion of somebody coming back to work on their first day without consultant cover, working in a system where the IT system is broken down, no proper induction, dealing with so many different things, and something went wrong and sadly a child lost their life. But for that responsibility to be placed entirely at that doctor, and first to be taken through courts for manslaughter, then to be suspended from the GMC, and then to be told that actually that's not harsh enough. We're now going to erase you completely from the register. It's one of those things where you can all put your hand in your heart and think that could have easily been me. I remember working in a situation where all things were against me. And I have no idea if a decision I made at that point may have resulted in that as well. We have made mistakes. There's not a single GP or a single doctor that who hasn't made a mistake. And sometimes that does result in bad outcomes. But you don't make that mistake with the intent of harming somebody. And that's raised more questions than answers. I'm not coming here to tell you that we've solved this, that this is the way to go. We seriously haven't. And it's caught us all by surprise, despite the fact that it's been going on for a considerable period of time. And the BMAs are mobilized behind it to try and understand where things have gone wrong and how to address it. And I think some criticism on the BMA has been fair, and some hasn't been. It's a clinical issue, it's a medical indemnity issue, it's been dealt with by indemnity organizations for that particular doctor. It's not something a trade union can get involved in, so we'll come and talk to you about your indemnity side of things. So we've not been involved in that process. It's not by choice, it's just by design. BMA is not the indemnity provider, it's an indemnity organization, so we've been out with it. But looking at what it's resulted in, we have now offered some support to Dr. Balgada's team to try and see if there's anything we can provide with a lot of national influence and so on. And almost by coincidence, we're already working on a piece of work about trying to get doctors to highlight working in a system that's under pressure. And these are the narratives that help, because at the moment the responsibility has been firmly placed at the clinician's feet, but the reality is there's got to be a responsibility of the system and the regulators to try and look at what's happening well and what's not happening well, and try to address those. There's something we need to keep an eye on, see how things go on going forward, but this has been the biggest shocking thing, certainly in my 20 years of going into medical school and general practice. I don't know, I've got a solution.
In Greater Manchester, we've had guidelines from David Valentine, who's the medical lead for appraisals from NHS England. I've not seen anything from VMA or GPC to GPs about what not to put in our appraisal folders for validation.
I'll explain that, if I may, in a very, well, not about it, let me say for answers. Whilst there is that piece of information on social media about the reflections being used in the court of law, I think there's two bits which confounded how that was actually played out. One, those reflections were presented by the defense team to the courts, so the prosecution never asked for those. And the courts right now can demand any piece of paper anywhere in the land for any case. So that's not something that's new that's happened. So it is, if the court demands a piece of paper from whatever it is that you have, even if you've written down a note on tissue paper at home, the courts can still demand it, so that hasn't changed at all. So from a GPC's perspective, what we were concerned about was the information that came out saying the prosecution used this to highlight the fact that this doctor's done something wrong. What we understand, again, we don't know all the details, it's only what the teams have shared officially with one another and what's been available on social media, is that the reflections were actually presented by Dr. Balgada's team to show that she has reflected on the things that have happened that day, and she's trying to learn from things that have happened to going forward, I think. So with that caveat, we just want to be slightly cautious saying to everybody, don't reflect anything in there. Because reflection done in the right way will work for you to have something on paper and go, yeah, I remember that, and I can do things differently going forward. But going to the other extreme of not putting anything down, that's put you at a different type of risk, I think. It's one of the reasons why we're holding up to it. We need all the facts. It's easy to comment on something when something becomes a huge issue on social media and say, that's true and that's not. But as a professional organization, you want us to give you the right information, right advice, even if it takes a little bit longer than something on impulse and shorthand. I mean,
Krishna, I don't think it's just social media. This is television, this is the press. There are people who've been standing outside the GMC on the streets. And there is a real sense of absolute anger we can take the pressure, we can, to an extent, we are doing, all of us sitting in the room here, and we're absorbing all this stuff from the patients. But you know what, when the GMC and when our senior leadership, I would tend to agree, when the senior leaders are not talking because they're thinking about how to respond whilst we're in the front line, I don't think that's acceptable. And that's poor leadership, and I think that's a sign of something I think that senior leaders, particularly clinical leaders and doctors, need to reflect on.
Sure.
Say that one of the reasons why we're in the absolute mess that we're in is because we aren't taking leadership and other people are telling us what to do instead. And often those people are non-medics telling what they think medics should be doing. And actually this should be a time when we should be out there fundamentally saying, what exactly do you want? Because if you want to tell us what to do because you feel you're better than us, then why don't we leave and you become a GP and you become a hospital doctor and all the rest of it and take responsibility for incredibly ill people. So I actually feel that this is not the time to be quiet.
Oh no,
This is the time
I think the point I was making there was about the particular point on reflections and appraisals and things.
Well,
it was more important to get the facts right before advice anything else. But in terms of supporting Dr. Gargara and making the right noises, they may wise about the JDC chairs and all the trainees.
So it's not just about Barrow because that's the whole, as you said, but by the grace of God it could have been you, or it could have been me or anybody else. And I think the thing is that this has now gone beyond Balgoa, where even this week, reflecting on some of the challenges we've had in practice, doctors who otherwise would have said, yeah, let's just squeeze another patient in, let's just see them because we know we're under pressure. Balgoa changes everything. You sit down and say, the partners have agreed, this is the number that we see, anything beyond that, don't tell the GMC. Because GMC will not thank us for seeing an extra patient.
Oh, absolutely.
And that's changed almost overnight this week. Last week.
I'm sure. The last 2-3 weeks has been, the feeling, I think, if there's one of those things that united the whole profession, it's probably one of these things. But which I really hope is what will reflect on where we have conversations about how we control our workload.
But I think that's why having all those senior leaders standing up on the front of the Times, BBC, whatever, turning around and saying this is not about Balgoa anymore because actually you and I, my GP is looking after me is now sitting there thinking I can't see you anymore. The goodwill goes when something like this happens, and GMC is really found wanting.
Oh, absolutely. And it's a spectacular role by GMC, but from our point of view, from a general practice point of view, we are much more exposed because we don't have I finished my shift and somebody else. You're there every day till 5:30 and you'll be on certain time to finish the work. And which is why I think when we meet at the conference, I hope the conversation we have about workload management and taking self-control and pushing back on the nonsense, because at the end of the day it's our name, it's us who are going to be getting into trouble, because the GMC won't thank us for us, just like he wants to do that. Will be different to the conversation we had 3 years ago when we were talking about workload. At that point, it's like, well, if I don't see my patients, who will? That was 3 years ago. I remember that very well. Brian presented that paper and stayed up and thought, this is not going the way it should have gone. I think it'll be a different conversation now. I think this has changed things. And I hope going forward we will start linking it differently rather than being the true altruistic GPs that my doors are always open, come home at night. Because I'll see you where I'm not. That may have been the case before, but it's a case going to be going forward. Absolutely.
Chris, I think it would be, what's I understand Amir's desire to get a quick answer to all of this. I think it's not good to rush into getting a sweeping piece of national guidance from GPC about this, and I think it would be seriously damaging to us if there was a move to stop formal reflection in appraisal, because I sit on the performance assessment group on behalf of GMLMCs, and we're often in managing complaints cases, it's very frequent that we're asking performers to reflect an appraisal and note down and discuss stuff. And clearly that's been shown to be a good thing to do. And I think if this case leads to a sudden cessation of that, I think that's a very dangerous road to be going down.
I'm not saying just GPC should do this. I'm saying every single senior clinical leader right across the system, whether it's NHS England, whether it's whatever, have got to stand, because at the moment you might be thinking about these things, but if we can't hear it, it feels as though you're just allowing it to happen. And that's not a good place to be.
And again, just we'll go into detail, there's a section GP's website on the BMA as well. If you're an employer, your information about the contracts as well as the resources that are available for your salaried GPs, by all means, go down to the website. There's lots of work that's going on about getting session GPs to engage more with the LMCs. I can't spend too much on these. Through the website, the next one, I think. Next one, yeah. So it's got all the resources there, which is really well organised. By all means, please do access it and let us know if there's any issues from there. We do have a Northwest regional rep for session GPs, who's pretty sure club, who's also now the deputy policy lead for commissioning and service development as well. So if not, by all means, get in touch with us and we'll put you in touch with the session representative as well. For you, how are you time-wise? Everyone all right? As I said, I'm going to keep doing this. So we're looking forward to the new models of care, but those of you who have to leave, please do. That's right. This isn't enough, so let's get that out there rather than trying to polish something which is unpolishable. It is little money, it is comes in drips and drabs. The amount of bureaucracy associated with most of GP4 is that's nonsense. But there are bits of money that, if committed to general practice and spent correctly with general practice at the centre of it, it will work. So there's a piece of work that GPC have done about 3 months for head transformation money. But NFO request to all the CCGs asking them if they're committed to spending this in helping general practice transform. And that showed that not everybody has. Certainly in my patch, we were asked to produce a business case to how this transformation money should be committed to general practice, despite the fact that it's been committed nationally by Amateur England to be spent on transforming general practice. And there is a GP4 View reference group that we host at GPC. So if you have got issues and barriers that you're facing as practices or LMCs locally with accessing GP4 View money, let your LMC know. Your LMC will be able to alert your regional representative, who will then bring it to NHS England essentially. And we've had the commitment from the likes of Don Hardy, Madan, who attend these meetings to say that if you tell us that there is a problem, we will take that away and get that resolved for you. And we've already had that. And I had an LMC from the North East who contacted me about the retaining scheme to say that their CCG have blocked it, saying that the money has to come from your baselines, therefore if you give your retaining GP, we'll have to stop doing something else. And it was really helpful that the CCG sent that down in writing in an email before it returned to England. 48 hours over Christmas, Don has spoken to the relevant people at those CCGs and got me a response back to say that no, we won't let that happen. So if things are happening to you, don't just deal with it and think, oh, this is it, and I'm not going to put up a fight. Try and put your case forward. If you need the LMC to support you, let your LMC know. If the LMC isn't getting anywhere, let us know in GPC. If you're not winning 1 in 10, the LMC will not win 1 in 100, will not win 1 in 1,000. But if you don't flat them up and escalate them up the chain, they won't in action. But we've got a commitment at the last meeting, and we had it before as well, but this one, in front of all the LMC representatives, Alice England said to us, if you're having this kind of nonsense, tell us, we'll deal with it. And it's the right one. And in terms of improving access as well, that's a new pot of money, which if you are in this transformation area, so you get a little bit more, but overall, we know about the money that's coming across from 6 months ahead in 2017-18 for the transformation sites and 3 months 24 for 18-19 for all the CCGs to improve access. This is different to the extra hours that we do. And this isn't supposed to be delivered by every single practice at a practice level. This is something that you get together in groups of GP practices to deliver. This could be something that helps you deal with the workload, or this could add to your workload. We're not going to know that until it really happens. We've got feedback from the Practice Challenge Fund sites. Remember the first feedback document that came out? It was spent, for every 5 million that you spent, you got 1.4 million pounds worth of saving. Or you lose 3.6 million. But you love how sometimes things are phrased and think that's how much you spend to make that much saving. What it means is it makes loss. But those kind of things, if you invest in something well, and if you have local GP engagement in delivering something that actually helps you control your workload, it'll be a good initiative. Otherwise it's not. But if you're not getting access to these funds, let the LMC know and let them escalate it to us, and we will definitely flag it up. And there's all sorts of other pots of money. There's a document on the BMA website about GP4 View and how you can access all these different funding streams. If I can plug my Homicide LMC, we developed it and BMA took it on and then added to it to make it fully comprehensive. But that document is there, which the details are every single pot of money that's available for general practice and when, and the criteria that you need to meet to access those funds as well. I mean, that's by no means, this is obviously a big thing in Manchester as well, bigger in Manchester than probably anywhere else in the country, is about new ways of working, and what that means for general practice and general practitioners and the patients that we look after. We can all recognize an element of working with somebody else to deliver something differently that helps you and somebody else and the patient. And that's not a new concept. That certainly isn't anything that needs to be sold to. Yes, okay, we can look at the model of general practice in the 1950s or 60s where you live upstairs, do surgeries downstairs, and your wife, reception, and nurse are all the same person. Whichever one they start with, they end up becoming the other two. So that is clearly gone from 60 years ago. It's now general practice. So you moved on while we're looking at stuff. There are ways where you can collaborate and make things work for you, but there isn't one way that fits everybody. So which is why the position we've taken is, we have examples which I'll share with you and talk about, where different models work in different places. All of them have been funded appropriately. There's been a vision, there's been local leadership and local ownership of those kind of models which will work. And where things are done to you, say you have to work this way, that's the only way. It's not something that we believe in at all. General practice has always been very plural and it will continue to be plural. You will come up with the solutions that will work for you. And again, all of this will make sense to you. There's certain things that you think are, these are great stuff. If you have 6 practices, why do you need 6 practice managers doing everything individually? Why not have 6 of them joining together, and all the 6 practice managers, one of them can become finance manager, one of them can become HR, one of them can become operations. The one you like the least can become the CPC person. You know, just put it in that way, and it will work for all of you. But imagine if they're all one practice, you only have one CPC inspection and not 6. How cool is that? So those kind of things do make sense. But on the other hand, what are you giving up? Yes, of course you're going to be giving up continuity of care if you become part of a huge practice if it's not organized properly. You may not necessarily see a patient. I worked in 2 large practices as a trainee, where one practice I never saw the same patient twice, and another practice I've always seen my patients, where I had, as a trainee, I had my own list that was under my trainer that I saw them regularly. So if you've done it the right way, and what do you find more valuable? For me, continuity of care is still very important. So I would want to work in a different model to somebody else. And when you become too big, you do have the risks of large organizations also have. Being is not always beautiful. So there are risks as well, but you will weigh risks and benefits and find what solution is for you, and not rather than saying somebody's already come up with one, that's where we're going to be doing it. And federations-wise, again, the notion of federation isn't new. Northern Ireland are really going very far with federations, how they can support GP practices locally, but there isn't one way of delivering it. I'm now sharing my example locally where we had a limited liability partnership, which is a federation of all our practices in the region. We had it for 2 years and we did absolutely nothing. So we've closed that. We've now created a community interest company, which is a federation of all our practices. It's coming up to 2 years when we still haven't done absolutely anything, so that's going to close soon as well. So the form has to follow the function, not the other way around. So if somebody says, this is the structure to federate, tell them to go away. What is it that you want us to deliver differently? Then you come up with a model that you think will actually meet your needs to deliver it. Not you should become this organization, and we'll talk about what you're going to deliver later on. Nonsense. Tell me that first, and that can come later on. And a very good example is the Tourist Federation in Herefordshire, which is an LMC-initiated federation, where every single practice in their patch, all 24 practices, join and form a limited liability company. They're all on one system. I'm not a proponent of EMSO's TPP system one, which I want to treat, but they're all on one system. And they offer some excellent services based on 3 hubs, and they've got all sorts of initiatives, and which makes them so much stronger. If every single practice in that patch is part of one organization, any kind of threat to the accountable care organizations and large companies coming in and taking over bits of it, you are the biggest player in town. No one else can mess with you. That's worked for them, great, but it's done by the providers, not by anybody else telling them how it needs to be done. That's a model that worked for them. But when you look at different models, super partnerships are models that work in different places. I mean, I've been to Birmingham to do the roadshow there, and you can almost say that's the centre of where super partnerships all started off, and where the different partnerships that are coming from are now spreading up and down the country. We've had a modality arrive in Hull, where they're doing the modality Hull division, which is slightly different to the modality versus Birmingham. The OHP, the Midlands Medical Partnership, and all of these things have worked in different structures. Go to the next slide. Where there's 38 practices with OHP in Midlands, they now moved to Shropshire, which is relatively close. speaking, but it's not right next to one another. But the model that they've developed has worked for places whereby they have central function economies of scale, the backroom functions that everybody can develop. If you need a set of policy for political governance, why do you need 38 practices to develop in 38 different types? You just need one, and all different practices can implement those. That's worked for them great. That's a model that's proven. They've been able to demonstrate that their model helped retain partners and salary GPs, offer them a career structure that actually kept the workforce within that team itself, and they're now trying to see how it will function in Shropshire. And they have a small corporate team that are paid for by the levy, which by the levy has an by their voluntary levy from practices, which is 2 points per head, which is complementary to what they pay to the LMC. So they know what it's doing. That's the LMC's function. They can support this because we're big, we contribute a lot to the LMC. That's what we do. It's the central function of our organisation. That's what they do. This is what we need to do individually at a practice level. The rest of the stuff, like GDPR things, imagine the number of practice managers that are going to lose their hair over the next 12 months or so. Most of you are a bit like me. And it is a challenge, because if you can share that of 38 of you, only one of you is going to end up looking like me, and the remaining 37 will be fine, that's a win. So you can kind of get with that with how these kind of models will work. And like I said, modality as well, they have a slightly different structure in the sense that whereas one model would be looking at having a partnership and everybody's partners in the larger organisation and all the revenue and costs are pulled in and everybody gets a share. The other model is looking at having an organisation at the top, but you have a local division that's a partnership there and another division that's a partnership there. The local initiatives will have local ownership and local revenues and local incomes and so on. Primary care home. Again, not a new concept, not something that no one ever thought of. It is another way of working at scale. It offers, provides a framework that's a little bit more easier to understand compared to when we talk about accountable care organizations, but it talks about groups of practices with patients between 30 and 50,000 where you can have a whole population health, which will work. And looking at the way of their regulistic care with local needs, but it's owned by GPs and GP practice rather than by vertical or horizontal integration as such. A new model that can work in places. And we've got an example in Cambridgeshire that's worked. They're planning on a sort of John Lewis type organisation where everybody who works within that primary care home has ownership of that primary care home. So you invest in it personally, you're not an employee, you're part of it, it's yours. And then what you put into it, you get your fair share back from it. These are the kind of models we want to see how they develop over the next few years. Is this something that's just started and stays, but then disappears, or is it something that's actually sustainable? But when we move on from these, and you get into the MCPs, which now, I think that's already 2 years old. MCPs moved on to accountable care systems, accountable care organizations, accountable care plans. Now it's going to integrate care health, and pretty soon they'll come up with something like a national health service. So, you know, all those concepts that have been around for how long time, they'll come back again. All they're saying is they've got to work in a different way. It's fine, but how? When you look at the contract guidance, we'll come back to that. The Hampshire one, yes, they have an MCP that's really successful, but that's worked really well because they've been very well funded to deliver an MCP that worked for them. If the same level of funding is replicated up and down the country, I would suspect most practices will say, yeah, okay, we'll pick up an MCP, but I can guarantee that level of funding is not going to be replicated up and down the country. So if you fund it that well to enable you, to give you the breathing space and room to improve on it, most people will. But if you haven't funded it and trying to deliver the same thing on the cheap, it won't work. But going on to accountable care organizations, about the different levels of accountable care, this is when the journey or the vision starts getting interesting. The first level, the level one of the vertically integrated model, whereby you still have your commissioner and you still have your general practice contract, which is GMS, PMS, APMS, and standard contracts to provide the rest of the services. The vision for a virtual accountable care system is that you have an arrangement, an agreement around all of that, whereby you look at stuff delivering something differently. It's not a contractual agreement as such, but it's an alliance agreement whereby it may be, I don't know, let's say phlebotomy. That'll be the easy one to start. This is how we're going to do the phlebotomy service across this patch. This is how the whole system is going to come into place to deliver that. And once you start on that journey, and you go to the next step, which is the second level, which is a partially integrated model, where you have commissioner, and then you have a GP contract, which sits with the GMS, PMS, and APMS of the practices, and you have everything else in a single 10-year agreement as nuanced in the ACO guidance, where the rest of things in there, we have to have arrangement with general practice and everything else. Kind of similar to what we have now, but although they are different conversations, you then end up having one. My concern with something like this always is when it's general practice versus everything else, we're the less fashionable ones. It's the everything else that tends to get the stuff. It's the trolleys in A&E that gets the attention, not the queues up to the GP practices that get the attention. I worry when we start going down this direction, especially when you're getting there, this sits uncomfortably with me, thinking we're going to be the ones that will have to compromise for the rest of the system to function. Like they have done during the winter precious money, where general practice was given 4%, and the rest of the system got 96% of the funds to get through the winter. 4%. Nowhere near enough. It's better than nothing, absolutely. Is it enough? No. And once we say 4% is enough, thank you very much, we're grateful, that's what we're going to get forever. So we need to fight for our corner, and I feel that this structure is where we start being put in our own corner and where those rest of the systems up against us. Which then brings us on to the division. Sorry.
That one that you've just presented,
Yeah.
the way I read it, that is the direction the whole of Greater Manchester has been pushed into. Because that is a local care organisation.
Yeah. And again, it comes with risks and benefits. If we go back to the previous one here, I'm sorry. On this one, you still retain your contract.
Yeah.
Yes, it gives you certain stability, but when this conversation happens, that's the risk keeping. That's where the local organisations will have to defend general practices corner and secure funding. Yeah, the plan would be in this bit, in the integrated agreement, they would be putting in things to say, if it's delivered in this way, this is what general practice will get. But without looking at the details and think how much of that will actually be beneficial for general practice. If they're paying you £10 per head to deliver something that costs you £12 per head, and you've got no choice because that's part of the agreement, it's nonsense. You're putting yourself at
They
risk.
say that that's what general practice will get, but general practice actually sits on the board of those organisations.
Yes.
With all members.
Yeah. I mean, and that's not a bad thing at all. If that then brings out a mission that actually makes it workable, that's beneficial for general practice, great. But if, once you're on the board, whether you'll still be able to do what you want to do for general practice, or whether then you end up with being accountable and being held responsible for delivering the rest, and then there's deficits here, the easier thing to do. In worst case scenario, I'm not saying it is all bad news, but if you've got £500 million worth of debt for the local trust, how tempted will you be to not come out with another enhanced service in general practice to fund some of the deficit? Especially if you put in directions like some of the CCGs have been doing currently, or they'll find a new set of words for the directions at that point in time. It's a risk. I mean, clearly there will be benefits if it's run correctly, but if you only look at benefits and not the risks, that's where obviously things will go wrong. I sincerely hope it works, but as I said before, the first level is where you can think, yeah, I can see myself as part of that. This is the point where I start feeling a little uncomfortable because I don't know all the details. It depends on what's put on in front of me and how that will work and how sustainable it is. If you fund it for 1 year and apply 10 people to deliver it and you take away the funding next year, then what do you do? It's those kind of things that make me a little bit more uncomfortable. And the third one, the next one, is a fully integrated one, which makes it very, very uncomfortable to me, whereby you think, they want me to give up my GMS contract and put it into that pot. Yes, in the document it says you can go back to your GMS contract, but if somebody could explain to me, 2 years after I've given up my list, all my staff have been TUP'd across the new organisation, and I don't think it's worked, and I said, right, can I have my patients back, my staff back, my building back, and I'd like them back in the next 2 months. No one's been able to nuance to me how that will work. Yes, on paper you can go back to your core contract, but once I give it back, for me, as far as I'm concerned, that's done. I can't see how it will come back to you. And I hate to end the conversation, I don't know what to say, and end the GPC contract, so I don't want you to remember that, so I don't want that to end. But that is an end to GPC contract. We've asked this question a number of times in our fellow team. Tell me how it will work if I want to get my contract back. How will I get it back?
I agree with your sentiments on that, but that's the same argument for OHP. You merge your contract with one single GP body. If you want to leave, you can't then go to the commissioner and say, I want to take my 10,000 patients out of the pool and set me all practice back up again.
Sure. On that one, all I would say is, if it's in a new partnership, it is between new partners how we negotiate that. In the same way that any partnership has disputes, how we split back into new practices. Whether you merge all your contracts into one contract, or whether you have one partnership agreement, but you hold independent contracts, is a great solution for this
So
one.
they've merged into one contract.
Not for everything though. Not for everything. For most of it, you're right, absolutely. Where I think it's working particularly in Birmingham area that they felt it's better for them. But in places they have specifically, well, in some areas they couldn't, because they got an APMS contract, which is now impossible to merge with GMS and so on. Whereas this one isn't even merging a contract, you're giving it up. It's just a GMS contract, it doesn't even exist. You can't even dispute and say, I want to get it back again.
That was floated around, actually, that when we were asking. At first it appeared that that's how it was going in Greater Manchester, but there was some backlash, and I think they actually stood up for ourselves on that one, and they pulled back from that because nobody wants to give up their GMS contract.
And if it's a partially integrated one that you're looking at, like the ones also mentioned, like I said, it does depend on what's actually on the table. The principle of where the agreement sits is what I tried to describe in the previous graph. But if it is an initiative that will actually work for you locally and it's developed with your input and it's something positive, good luck, go for it, try and do it.
It's also how it's delivered to you though.
Yeah.
You know, because very often it's delivered as you can have this or you can have that other one, which one's best for you?
Yeah.
You're like, well, we kind of don't want either, but we'll go for the lesser of the two evils, which is...
That was part of the
where a lot
negotiation strategy training that I learned, where they said you have to make somebody offer of 3. 2 look equally bad and 1 look less bad. So that's the one you actually want. So you start with one, you continue to make something else look worse, and you get what you actually want. But the reality is, this is a journey that hasn't been tried before. This is the fully integrated model, a threat to the list-based general practice, where it is very difficult to go back. If, as I said, I'm happy to change my mind if somebody tells me how you can go back from there, and we can't. The virtual one, as I said, it sits uncomfortably with me, but if it works well with appropriate local leadership and ownership, then all the best, because we do need something clever to happen for general practice in the absence of government not funding general practice the way we need it. So I'm half an hour over schedule, and I said I can speak for another hour, or stop or let someone go home, but I'm happy to take any last questions. Or if you want to get in touch with us, the next slide, those have our contact details. So I'll shut up. Thank you.
Thank you very much, Commissioner.
Any final questions?
Anybody else spoken? Anyone at this table here?
You were saying that you felt there was a change in mood with negotiations. Is that a genuine...
Not changing in negotiations, a change in rhetoric from them centrally. Because we'll remember 4 or 5 years ago, we had a contract imposition where we were saying we were struggling. Nobody else actually acknowledging that the Democrats were struggling, and they still decided to go ahead with the AUA days and all that kind of nonsense, which hasn't been helpful. Whereas the conversations now have been, look, what needs to be done, what's on offer, what are the kind of things general practice can deliver, and how can you support this better. But more than what happens in negotiations, which are confidential conversations, what I was more interested in is what they say publicly about how they're going to support general practice. So until last year, the submissions from the department and everything have been very, we did well, we got plans, everything we sorted out. Do for the first time now say, actually, we're a bit of bother, we need to do things differently.
So you think they actually get it?
Yeah, absolutely. So now when we talk about campaigning and lobbies and bodies, I think that bit we won, they now get it. The challenge now they have is to try and get the Treasury to commit the level of funding that we need as general practice to make ourselves sustainable and resilient.
Thank you very much.
Great.